So good afternoon or good morning, everyone. Welcome to today's session of the R3 seminar series, Long COVID After SARS-CoV-2 Infection During Pregnancy. My name is Patrick Ahern with RTI, and I'll be helping out with the virtual room today. So just a few quick notes before we get started. When you log in, your microphone will be automatically muted. But if you have any questions for presenters today, please submit those into the Q&A window. And if you run into any technical issues with the Zoom, please let me know in the Q&A window as well. We do have closed captions available during today's webinar. Just click on the Show Captions button on your main Zoom toolbar to turn those on. And towards the end of today's session, we will launch a brief feedback poll, and the Recover team would greatly appreciate your feedback. So at this time, I'll go ahead and turn things over to Quinn to kick off today's session. Thank you.
All right, thanks, Patrick. Welcome, everyone, to the Recover Research Review, or R3 seminar. My name is Quinn Barnett. I'm an epidemiologist with the Recover Administrative Coordinating Center, and I'll be your moderator for today's session. The goal of this seminar series is to catalyze a shared understanding of the research within the Recover Consortium. I want to start by thanking everyone who submitted questions in advance and remind everyone that you can submit any questions during today's presentation using the Q&A feature in your Zoom menu. After today's panel, our speakers will answer as many questions as possible. The Q&A document will also be posted with the recording of the seminar on recovercovid.org. The document will include the answers for submitted questions relevant to today's presentations. Questions about other scientific topics will be addressed in future seminars, and answers to broader questions about Recover will be available in the FAQs found at recovercovid.org. As a reminder, we cannot answer questions about individual clinical care. I'm pleased to share that our panelists today are Dr. Torri Metz, Dr. Chengxi Zang, and our discussant will be Dr. Valerie Flaherman. Dr. Metz is Vice Chair for Research and Chief of Maternal Fetal Medicine at the University of Utah Health, where she also serves as an Associate Professor of Obstetrics and Gynecology. A practicing maternal fetal medicine specialist, she leads NIH-funded research on pregnancy outcomes related to cannabis use and long-term effects of COVID-19 during pregnancy. Dr. Metz serves as a principal investigator for the NIH Recover Initiative, as well as the Utah Center of the Eunice Kennedy Shriver NICHD Maternal Fetal Medicine Units Network. Dr. Zang is an assistant professor in population health sciences at Weill Cornell Medicine and a faculty member at the Institute of AI for Digital Health. His research focuses on using AI and real-world data to generate robust, generalizable evidence to tackle major health challenges, including long COVID, Alzheimer's, youth suicide, and women's health. His work has been published in top journals such as Nature Medicine and Nature Communications, and has been recognized by the American Medical Informatics Association, among others. Dr. Flaherman is Professor of Pediatrics and Epidemiology and Biostatistics and core faculty at the Institute for Health Policy Studies at the University of California, San Francisco. Her primary research focus is preventive interventions in the newborn period and newborn care. She's currently co-principal investigator of the Pregnancy and Coronavirus Registry Study and the Recover UCSF Pregnancy Cohort, as well as managing director of the Better Outcomes Through Research for Newborns Network. The topic of today's seminar is long COVID after SARS-CoV-2 infection during pregnancy. Today's speakers will present findings from two studies about long COVID risk following SARS-CoV-2 infection during pregnancy and the associated risk factors. Findings are from the multi-site Recover Pregnancy Cohort and retrospective analysis of electronic health records using the PCORNET and N3C databases. Please welcome all of our speakers, and with that, I will turn it over to our first speaker, Dr. Flaherman.
Thank you so much, Quinn. It's a pleasure to be here today talking about long COVID after SARS-CoV-2 infection during pregnancy. Next slide. When I think about SARS-CoV-2 during pregnancy, I know that the prevalence of long COVID is high. The population point prevalence estimated by the CDC is 6%, and about 10 to 25% of people experience long COVID after SARS-CoV-2 infection. The biological mechanisms causing long COVID are not yet well understood. Two possibilities are an overactive immune response to the viral trigger or viral persistence with the persistence of either virus or fragments in various tissues of the body. And pregnant people may have distinct risks because pregnancy is immunomodulatory. The reason for this is that a pregnant person needs to have immunomodulation to prevent mounting an immune response against the embryo and developing fetus, which is essentially foreign tissue inside the pregnant person. And this immunomodulatory response could potentially protect against long COVID if, especially to the extent that long COVID might be due to an overactive immune response, or alternatively, could increase risk, especially if viral persistence represents a continuing trigger. Next slide, please. And so studying long COVID presents unique opportunities and also has unique challenges. It's an important topic because there are 4 million pregnancies per year in the US and lots of SARS-CoV-2 infections. So many people are potentially impacted. But studying long COVID during pregnancy also has the possibility of informing the development of immunomodulatory therapies for other groups. Because if we learn about how long COVID differs for following SARS-CoV-2 infection during pregnancy, that may help us understand more about the immune mechanisms underlying long COVID. At the same time, studying long COVID in pregnant people has challenges. First of all, many of the symptoms of pregnancy, such as fatigue, brain fog, difficulty sleeping, may mimic symptoms of long COVID. And these can continue into the postpartum period. So following people after SARS-CoV-2 infection during pregnancy, when they're postpartum, may have some of the same challenges. Additionally, some outcome assessments may be unsafe during pregnancy. And a final challenge is that, of course, when it comes to recruitment, pregnant and postpartum people have many demands on their time and may be difficult to recruit. Next slide. With all those opportunities and challenges, the primary research goal of Recover's pregnancy cohort is to enroll maternal child dyads to investigate the effect of SARS-CoV-2 acquired during pregnancy on the long-term health of both the pregnant person and their offspring who are exposed to SARS-CoV-2 in utero. In this presentation, we'll be focusing on adult health, but we'll be reporting on some of the offspring outcomes in future work. Next slide. This is a schematic of our pregnancy cohort, and you can see that in Recover, we've enrolled pregnant individuals and those postpartum who were either exposed or unexposed to SARS-CoV-2 during pregnancy, and we're following them over time. We have a good portion of controls, but most of our participants were exposed to SARS-CoV-2 during pregnancy and enroll in Recover either in the acute phase, immediately following SARS-CoV-2 infection, or in the post-acute phase at a point in time in the future. As I mentioned, we're following the offspring through 48 months of age, and that work is ongoing and will be hopefully reported shortly. Next slide, please. In Recover, our pregnancy cohort adults follow all the study procedures of the adult cohort, including tiers 1, 2, and 3, with deeper phenotyping by tier. There are some modifications for the pregnancy and postpartum state. First of all, of course, we do not evaluate weight loss among postpartum people, as that's expected. And we do not perform exercise testing when participants are pregnant. That needs to wait for the postpartum period. In addition, some imaging studies with radiation are not safe for pregnant people and are not performed for Recover adults in the pregnancy cohort. So the prospective Recover observational pregnancy cohort has important strengths and important limitations. Our strengths include our detailed outcome assessment, which includes collection of biospecimens, physical exam findings, and clinical tests conducted with research protocols to research standards. The prospective observational cohort also has the ability to survey participants, and participants answer extensive questionnaires on quality of life, mood, income, household functioning, and the overall impact of both the virus and long COVID on their themselves and their family. So while the prospective observational cohort has these important strengths, it also has some limitations. Symptoms are assessed by self-report. And every observational cohort has the potential for selection bias, both in the enrollment process and in follow-up rates and outcome assessment. We'll also hear today some important results from Recover's EHR cohort, which includes PCORNET and N3C, together with about 50 million patients and harmonized EHR data that includes access to clinical notes and access to claims data. Next slide. And the EHR cohort also has important strengths and limitations. Strengths of the EHR cohort include its large sample size and comprehensive clinical outcome assessment with collection of all diagnostic codes assigned by clinicians. Another important strength of the Recover EHR cohort is that because it's administrative data, it's a fairly representative data set with less selection bias than would be seen in a prospective enrollment cohort. On the other hand, Recover's EHR cohort also has limitations because it includes only clinician report of symptoms, which may not fully reflect patient experience of symptoms. And we often hear from our patients and also from the patient representatives on Recover that patients with long COVID may not bring their full range of, they may not report their full range of symptoms to their clinicians, and they may also avoid seeking care when they're feeling particularly unwell. So that's an important thing to keep in mind in interpreting EHR data. Another limitation of the, another limitation of the EHR cohort is that it has few, because of the administrative nature, it has few quality of life measures and doesn't collect biospecimens, although of course it does have a rich array of lab tests that were run as part of clinical work. So the Recover Consortium is really designed for these two study designs to work together to provide insight into the impact of SARS-CoV-2 infection during pregnancy on health outcomes. And together with the strengths and limitations of the two different cohorts, I think we can present a very important insights into how SARS-CoV-2 affects people during pregnancy. And with that, I'd like to turn this over to Dr. Metz, who will be presenting on the observational cohort.
Great. Thanks so much, Dr. Flaherman. I'm going to share my slides here. All right. Hopefully everybody can see those okay. Thank you so much for joining today. I'm going to talk about some initial results from the pregnancy cohort, which we spoke about in the introduction. And this is the observational portion of Recover, in which we are studying, risk factors and pathophysiology for long COVID. My talk is called Development and Post-Acute Sequelae of SARS-CoV-2 After Infection During Pregnancy. And again, this is part of the NIH Recover pregnancy cohort. I do have a couple disclosures. I was a site PI for a Pfizer study of the COVID-19 vaccination and pregnancy. Money was paid to my institution to conduct the study. I was also site PI for a Pfizer study of the pharmacokinetics of Paxlovid in pregnancy for treatment of mild to moderate COVID. And money was also paid to my institution to conduct that study. And so Recover Pregnancy, this is the overall aim, will enroll maternal child dyads to investigate the effects of SARS-CoV-2. Just gonna minimize this. Acquired during pregnancy on the long-term health of both the pregnant person and their offspring who are exposed to SARS-CoV-2 in utero. This is what Valerie showed previously and just shows you the setup for the Recover Pregnancy cohort with an overall goal of collecting 2,300 pregnant individuals and 2,300 offspring data for investigation of these important research questions. SARS-CoV-2 increases the risk for serious maternal morbidity, stillbirth, preterm birth, hypertensive disorders of pregnancy, and other complications in pregnancy. We know that pregnant people have a higher risk of developing severe COVID-19, having an ICU admission during the acute infection, and death, which makes us really interested in this unique population in terms of long COVID as well. 10 to 25% of non-pregnant adults infected with SARS-CoV-2 develop post-acute sequelae of SARS-CoV-2 or PASC or long COVID. There's an increased risk with early variants, higher disease severity, medical comorbidities, and among those who are unvaccinated. We all know that this is a public health crisis that requires ongoing attention. It remains unclear how pregnancy affects long COVID. The NIH Recover cohort was designed to understand the prevalence and pathophysiology of PASC or long COVID, and we established the Recover Pregnancy cohort to follow people with SARS-CoV-2 during pregnancy because we thought we may observe a differential prevalence or risk factors for long COVID. Our objective of this initial analysis was to estimate the prevalence of post-acute sequelae of SARS-CoV-2 infection or long COVID after infection with SARS-CoV-2 during pregnancy in the Recover Pregnancy cohort, the observational cohort, and to characterize the associated risk factors for long COVID in this population. We used a multi-center observational cohort design. Participants were enrolled between December of 2021 and September of 2023 across 46 states plus Washington, D.C. In-person study visits occurred at 26 sites participating in the NICHD Maternal Fetal Medicine Units Network, which is a large clinical trials research network, and remotely nationwide by the University of California, San Francisco. Participants completed surveys on their long COVID symptoms and severity as we conducted these study visits similarly to all of the other adult cohort study visits. We included for this particular analysis participants in the Recover Pregnancy cohort who are pregnant at the time of their index SARS-CoV-2 infection, and we excluded anyone with no available study visit with long COVID symptoms survey 6 months or more from the index infection. Our primary outcome was PASC or long COVID at the first study visit 6 months or more from their index or initial infection. And we defined that using the NIH Recover adult long COVID scoring system that was developed based on the presence and severity of self-reported symptoms. For those who aren't familiar, these scores range from 0 to 34. For this analysis, participants with a score greater than or equal to 12 were considered PASC or long COVID positive, and the others were considered indeterminate. And the reason we used 12 for this analysis was because we did not yet have the updated long COVID research index that's been published that actually modified this and indicated that we should be using a score of 11 or more. But for this particular analysis, it was performed before that time, and we used a score of 12 or more. What we found is that there are a number of risk factors for developing long COVID after acquiring SARS-CoV-2 during pregnancy. The sociodemographic risk factors that we identified were patients' insurance status at enrollment, with those who are publicly insured having a higher risk. We also looked at self-reported difficulty covering expenses and paying bills. We also looked at self-reported experience of discrimination measured by the Everyday Discrimination Scale. And apologies, the results are coming up. Other factors that we looked at were some pre-existing clinical characteristics. So we looked at vaccination status. We looked at self-reported medical comorbidities such as tobacco use, obesity, hypertension, and depression or anxiety disorder at baseline. We also examined some index SARS-CoV-2 infection characteristics, such as the severity of the initial COVID-19, the trimester at the time of infection during pregnancy, and the calendar time of the index infection as a proxy for the variant. In terms of the analysis for this project, we looked at both unadjusted and adjusted odds ratios between each risk factor and PCORNET long COVID status estimated using multivariable logistic regression. That's just a fancy way for saying we tried to account for all of the other factors to really determine what risk factors were independently associated with developing long COVID. Missing covariates were addressed using multiple imputation, and a sensitivity analysis was performed, which excluded study visits when the patients were still pregnant or within 12 weeks postpartum. So like Valerie was talking about, a lot of the symptoms of pregnancy and in the postpartum period can overlap with symptoms that are reported by people with long COVID. So what we wanted to do is also look at if we take out the participants who were still pregnant or who were within those initial postpartum period, did we have different results? And then we also did a complete case analysis to assess handling of missing data, meaning that we did a separate analysis where we only included participants who had all of the data available that we were interested in. So here are our results. We started with over 14,000 participants in the NIH Recover Adult cohort. We excluded males, people identified as intersex or missing sex, and those who are above reproductive age. So for this, we define that as age greater than 45 or unknown, and people who are uninfected. We then boiled it down to infected reproductive age female sex at birth. We excluded people who were not pregnant or no pregnancy information. And then we excluded those who didn't have any information more than 6 months from the initial index visit and index infection, so the 6-month study visit, and ultimately ended up with a final cohort of 1,502 participants for this analysis. 61% of the participants had an index SARS-CoV-2 infection on or after December 1st, 2021, meaning during the time of Omicron dominance or later. 48% had index infection during the 3rd trimester. 51% were fully vaccinated at least 2 weeks prior to the index infection. 24% reported obesity in the year prior to infection, and 29% reported other medical comorbidities. This is a result with our primary outcome, where we were trying to look at the prevalence of long COVID in this population who acquired SARS-CoV-2 during pregnancy. We found that 9.3% of our participants met our criteria for PCORNET long COVID. And on the graph on the right, you can see how the breakdown of the long COVID research index, or PASC score, as we previously called it. And you can see that the majority of these participants had scores of in the 12 to 16 range, with a smaller proportion having the higher PASC scores, and that sort of tapers off across the graph, with the PASC score being on the bottom there, and the frequency on the y-axis. The median time from index date to PASC defining study visit in this analysis was 10 months. So that means that most frequently, that's the timing that we were assessing the long COVID symptoms from the initial SARS-CoV-2 infection. The most common PASC symptoms that we saw were post-exertional malaise, fatigue, gastrointestinal symptoms, dizziness, and brain fog. And here are the results regarding the risk factors, which I apologize, I started to talk about earlier. So we found that people who had difficulty covering their expenses, people who reported that they had obesity prior to infection, people who had depression or anxiety at baseline, and people who required oxygen for their acute infection, indicating a higher severity of infection, were all at higher risk for subsequently developing long COVID. We also found that infection pre-Omicron, we also looked at infection pre-Omicron, being not fully vaccinated, looked at a discrimination index and medical comorbidities. And what you can see here when you look at these adjusted odds ratios is that they all cross 1. So even though we found that the things we expected. There was a little bit higher odds of developing long COVID for infection pre-Omicron, not being vaccinated, being discriminated against, having other medical comorbidities. Because these confidence intervals cross 1, they weren't statistically significant in our results. We did the sensitivity analysis that I talked about, and the results were similar in the sensitivity analysis, excluding those who were still pregnant and within 12 weeks postpartum at that PASC defining visit. So meaning that we took out those participants who were still pregnant or postpartum. And these results were also similar in the complete case analysis for those who had complete data for. The limitations are that the PASC outcome definition was based on an algorithm creating an overall PASC score, or the Long COVID Research Index, as you would now be familiar with it. People do experience, we know, different symptoms and severity, and this likely did not capture all patients who would be diagnosed with long COVID in the clinical setting. Some PASC symptoms were common, nonspecific, and can overlap with those seen during pregnancy or postpartum. But like I said, our results were very similar, even when we excluded those who were still pregnant or postpartum. And we know we cannot estimate the true population prevalence of PASC because, as Valerie mentioned, this isn't a population based study. It's really people who were referred in or presented to specific medical centers. The strengths are that it is a multi-center and diverse population. The PASC symptoms were collected in a detailed way and collected prospectively, and sampling was not limited to those previously identified as having PASC. We did an established scoring system to identify those with PASC or long COVID, now known as Long COVID Research Index. The conclusion is that 1 in 10 individuals with SARS-CoV-2 during pregnancy developed PASC or long COVID. The symptoms included post-exertional malaise, fatigue, and GI symptoms predominantly. There were specific socioeconomic and clinical characteristics that were associated with the development of long COVID, and the rates of long COVID among pregnant populations may be lower than non-pregnant adults, with estimates ranging from 10 to 25%. And this was interesting to us, and we think warrants further investigation. It's important to understand if there's a differential risk between those who are pregnant and non-pregnant, as it may help us better understand the pathophysiology of long COVID. Where do we go from here is the question. There are many complexities with changes in the immune response during pregnancy and differences in the levels of sex hormones, which may also affect long COVID prevalence. Female sex has been associated with a higher risk of long COVID, and both estrogen and progesterone increase in pregnancy. So it's biologically plausible that we could see differences in risk. So this really led us to a new research question, which is, are people who are pregnant at the time of SARS-CoV-2 infection at differential risk of developing long COVID when compared with reproductive age females who were not pregnant at the time of infection? And we wanted to really analyze this very rigorously. So we've designed a study to do exactly this. We're again using the Recover observational cohort data. We are again including females aged 18 to 45 years with an index SARS-CoV-2 infection on or after December 1st, 2021. And what we're going to look at with this upcoming new study is also these completed surveys of long COVID symptoms and severity that we have as part of the adult portion of the Recover observational cohort. For this upcoming analysis, we are going to look at a primary exposure of having SARS-CoV-2 during the pregnancy. We're going to look at a primary outcome of long COVID at the first study visit 6 or more from the index infection. And long COVID will be defined using the NIH Recover adult PASC scoring system developed based on the presence and severity of self-reported symptoms. And for this analysis, we will use the new data, which indicates that we should use a score of greater than or equal to 11. Our plan is to use propensity score matching to balance the groups on variables potentially associated with both pregnancy status and long COVID. So I think this is the part that's really important, is when we can look at these groups and compare those who are pregnant and non-pregnant when they contracted SARS-CoV-2. What we want to do is balance them on everything possible to see if there really is a differential risk that we can subscribe specifically to being pregnant. And we want to know if there are differences between the groups, if they're a function of differential baseline health status, younger age group, etc. And we do worry about this, and that's why we want to use this propensity score matching in order to kind of take away those components to really look at pregnancy specifically as a risk factor. So these results are pending. Hopefully I can share them at an upcoming R3 seminar. We have performed this analysis and submitted a manuscript for publication. And as soon as it is published, we'd love to share that with the group. Concurrently, we've examined the same research question in collaboration with the EHR cohort that Valerie spoke about early in this talk. And Dr. Zang is going to be here to share those results with all of us today. I would like to thank the Recover Pregnancy sites and the participants and patient representatives who have contributed so much to this NIH Recover initiative. Here are the sites listed here, and I will go ahead and turn this over to Chengxi. Stop sharing. Thank you.
Thank you, Torri. I'm also going to share my screen. Give me a sec. Can you see my screen? Just check my screen. It
Looks
works
good,
well.
yes. Mhm.
Thank you. Hi, everyone. This is Chengxi Zang from Cornell Medicine. Thanks for having me here. I'm from the Division of Health Informatics and Artificial Intelligence, Cornell Medicine. And today, my presentation title is Long COVID after SARS-CoV-2 infection during pregnancy in the United States. This is the results from PCORNET EHR in adult cohorts. And okay, yeah. All right, the agenda is a typical one. I will start with background, followed by methods, results, and the discussions. And this is a little busy slide to summarize the background. We know a lot of knowledge is on long COVID. However, existing long COVID knowledge is majorly derived from general populations. And however, as introduced by Torri, pregnancy is also associated with an altered immune response, and its clinical manifestations of COVID-19 is a little different. And the SARS-CoV-2 infection in pregnancy and its impact on long COVID remains largely unknown. There are several literatures on the physiological changes in pregnancy, and also Torri and the teams and others also gave a lot of great seminar works on the COVID-19 on the worst perinatal outcomes, increased risk of mortality, and obstetric complications, and both can impact short-term and long-term quality of life and of the offsprings. And also, as introduced by Torri and Valerie, and the SARS-CoV-2 infection in pregnancy and associations with long COVID remains unknown, and it's conducted by the prospective cohort right now. And also, we also have preliminary results published in Clinical Medicine. It's based on a relatively small PCORNET EHR cohort to investigate the prevalence incidence of long COVID and its relative risks. So there are several knowledge gaps here. Existing knowledge is majorly based on from relatively smaller cohort with limited sample size, and which might limit the generalizability of the current findings, and also might limit the investigations of different subgroups and its differential, long COVID manifestations, like stratified by the gestational age and multiple, comorbidity conditions, vaccine status, and so on and so forth. And thus, we just leverage efforts across different cohorts, including Recover PCORNET EHR, Recover N3C EHR, and Recover pregnancy cohort. We together want to investigate and leverage different cohorts to increase sample size and to leverage strengths from cohort to study these. So this is our Nature Communication papers titled Long COVID after SARS-CoV-2 during pregnancy in the United States. And thanks for the co-authors, Daniel and co-supervised by Torri, Yilin, and Thomas Carton. And Valerie just gave an excellent introduction of the overall governance structures And this work is a collaborative effort across cohorts. It's a fantastic collaborations from EHR cohort, PCORNET adults, N3C, and the pregnancy cohort. And we leverage two large nationwide data sets. One is the National Patient-Centered Clinical Research Network, PCORNET. Other is the National COVID Cohort Collaboration, N3C. In total, there are more than 5 million patients harmonized EHR data, and we have access to clinical notes, and we together try to answer the questions regarding the pregnancy, COVID during pregnancy, and long COVID. You can see the sites across the United States, several overlap sites, and the two independent cohorts to cross-check, to increase the sample size as well as to cross-check and make the data results more generalizable and robust. And here is our approach. So we built our cohort from the two independent real-world data EHR from PCORNET and N3C. The study period covered from the very beginning of the pandemic. Sorry about that. This is the very beginning of the pandemic to the 2023 June. And our exposure of interest is SARS-CoV-2 infection during pregnancy. You can see here, this is the first SARS-CoV-2 onset during the pregnancy versus outside the pregnancy, namely the non-pregnant SARS-CoV-2 infected patients. And so we started from more than 10 million SARS-CoV-2 infected cohorts, and we required adult cohorts at the reproductive age of the populations older than 18 and younger than 15 years old, and they have the access to the healthcare utilities during the baseline, and we require enough follow-up period to ascertain their long COVID conditions. And as I mentioned, we compare the SARS-CoV-2 infected during pregnancy versus outside the pregnancy. So we captured the baseline covariates. You can see prior 3 years before the SARS-CoV-2 infections. After SARS-CoV infection, the first 30 days are acute phase, and we ascertain the long COVID during 30 days to 180 days after the SARS-CoV-2 infection. This is our experiment setup. And our primary long COVID outcomes, and for different cohort, we leverage different computational phenotyping algorithm to capture long COVID. Regarding the PCORNET cohort, we use PCORNET long COVID definitions. It's based on our previous work, several previous works published in Nature Communications, Nature Medicines, etc. Overall, it's a rule-based definition determined by the real-world data, clinical knowledge, leveraging the ICD-10 codes. And you can see this is any of the following conditions across different organ systems. And it's a rule-based and interpretable and ICD-10 based from EHRs. And N3C long COVID definitions is also based on their works in Lancet Digital Health and follow-up updated versions. They developed a machine learning-based models trained to predict long COVID diagnosis. And in addition, we also capture other, long COVID subtypes and different definitions to cross-check across two cohorts. One is the cognitive fatigue and the respiratory symptom clusters. This is developed from this JAMA paper. Another one is we check the unspecified long COVID diagnosis U99. This is the ICD-10 codes for post-COVID-19 conditions, unspecified, and another B948. This is a diagnostic code used before the onset of U99. Together, we use these two ICD-10 codes to cross-check the to cross-check the long COVID conditions. Some statistical method details. So first of all the analyses were conducted separately for the two cohorts because of the data stored in separate system. However, we follow a common protocols and we follow exactly the same statistical analytics. And we match the two exposure groups based on the site, age, infection time, acute severity, and some baseline conditions, including diabetes, hypertension, autoimmune, mental, and obesity, asthma, etc. Key conditions suggested by clinician teams. And we match the SARS-CoV-2 infection during pregnancy and match with the ratio 1 to 3 for the control groups. We further use inverse probability of treatment weighting to further adjust for potential residual confoundings. And regarding the outcomes, we captured the cumulative incidence by using the Allen-Johnson models, and in the weighted population by considering deaths as a competing risk, and also captured the hazard ratios modeled by Cox survival models, and to capture the hazard ratios and relatively risk. All right, so regarding the results, and this table summarizes the population characteristics of the SARS-CoV-2 infected pregnant females versus the matched non-pregnant controls. Overall, we can see the groups with a median age of 13 years old in two exposure groups. From the PCORNET cohort, you can see from N3C, the similar ages, and they are more likely for in the age group 13 to 35 years old. And we can see the two groups are comparable. Also, their self-reported race and ethnicity distributions, we can see a little cohort difference between the PCORNET and N3C. You can see the distributions are a little different. Also, the distributions regarding across their baseline conditions. So, for example, they have baseline anemia, asthma, etc. And overall, by doing the matching and etc., statistical methods, we try to make the two comparison groups comparable and suggested by these population tables. And the results. This table summarizes the risks of the long COVID. So I just highlight something, some key takes in the red rectangles here. You can see overall there per the PCORNET rule-based computational phenotyping algorithm for long COVID, we observed 16.5 cases per 100 in pregnant females. And by contrast, in the control groups, the long COVID cases is around 18.9. Thus, we can see suggested by the hazard ratios is lower than 1, which means relatively lower risk in pregnant females. And we can see this relatively lower risk across different subcomponents of this long COVID definitions across different organ systems. And regarding the machine learning-based computational phenotyping algorithm developed by N3C cohort, we can see their absolute risk is a little different by their different nature of capturing different long COVID, aspects. However, their relative risk is again the same, relatively lower risk in pregnant females. You can see this is smaller than 1 based on the adjusted hazard ratio. All right, so thanks to the big EHR cohorts, which empower to investigate long COVID in different subgroups, and several takes here. The first one is a relatively lower risk across different subgroups, stratified by the race, age, trimesters, infection time, BMI, baseline risk factors, etc. We can see overall, we observed relatively lower risk in pregnant groups compared to matched non-pregnant groups. And several exceptions is a little higher risks when pregnant females infected during the first or the second trimesters. And this is some only exceptions here from the EHR observations. The second one is regarding the absolute risk. So this is the cumulative incidence in the pregnant group. We see higher absolute risk in self-reported Black cohort. You can see this is 19 cases per 100 compared to white is 15 cases per 100. advanced maternal age with threshold 35 years old, we can see this is 70.8 cases per 100 compared to younger group, this is 16. And also, pregnant females get infected during their first or second trimesters. You can see here, compared to third, we can see higher absolute long COVID risks. And also, patients with obesity, you can see this is close to 18 cases compared to 16 cases with normal BMIs. And also, patients with baseline risk factors, they are more likely to develop long COVID compared to those without the baseline risk factors. And also, these results are robust and consistent in both PCORNET cohort as well as in N3C cohorts. They follow the same patterns. As another sensitivity analysis, we also check the risk of other, long COVID definitions. For example, U99, as I mentioned earlier, this is long COVID diagnosis, as well as the cognitive fatigue respiratory condition subclusters. We found relatively lower risk in pregnant females, and in both PCORNET and N3C cohorts, and also the relatively lower risk regarding the CFR condition clusters. And also we observed similar absolute and relative risk across two cohorts, right? PCORNET and N3C, similar, absolute risks and relative risks here. So which means suggesting results are consistent and robust. To wrap up the findings, we observed a relatively lower risk of long COVID in pregnant females and SARS-CoV-2 in pregnancy compared to matched non-pregnant females, which means SARS-CoV-2 outside pregnancy. However, long COVID incidents are still significant among pregnant individuals, and we observed higher long COVID risks in self-reported Black patients compared to white patients with advanced maternal age, those infected during the first 2 trimesters, and those infected during the post-Omicron variants of concerns compared to our previous ones, and also pregnant females with obesities and comorbid conditions compared to those without. And some suggestions. So this is a real-world data from 2 large independent clinical research networks and potentially better statistical powers because of the sex to the bigger cohorts and potential leading to better generalizability. And we also validated the results from 2 independent cohorts and also to further support the prospective observation cohort from the pregnancy cohort. And we also use different long COVID definitions and as well as other long COVID subtypes. So all the results are consistent and further make our findings more robust. However, because this is an observational EHR cohort, there are potential residual confounding issues and potential misclassifications of pregnancy and study variables using EHR data. And also we acknowledge not enough vaccine data because of the low vaccine rates in pregnancy or the missingness in the EHR data, which make a confident conclusion about the association between vaccine status during pregnancy and long COVID and requires further studies. So based on our current findings and limitations, we are just calling for continuous prospective studies and EHR observational studies on pregnant individuals, and also other hypotheses pop up during our research journeys, like long COVID on pregnancy outcomes, and which all require more data and bigger cohort collected over time. And also because we observed relatively lower risks in pregnant females, which also call for mechanism understandings. And also, because of the vulnerable pregnancy patients, we just require more robust, intelligent, and safe drug developing pipelines and leveraging, for example, observational real-world data, for example, using the real-world data-based drug repurposing to inform the drug development and as well as to inform trial design. All right, thank you. That's all of my presentations. Glad to take the questions and comments at the end. I will turn the screen to the moderators. Thank you.
Great. Thank you, Dr. Zhang. I think we will move forward to Dr. Flaherman for a few questions.
Yes, it was Torri and Chengxi. Thank you so much for those wonderful presentations. I think you know, even after having read the papers, it's always so interesting to hear you all present it and the different aspects of the impact of SARS-CoV-2 infection during pregnancy on population health. Maybe I can start out with a question for Torri. When you think about the development of long COVID following SARS-CoV-2 infection during pregnancy, are there other conditions that either are more likely or less likely to develop during pregnancy that might provide parallels or insights to the process by which long COVID is impacted by pregnancy?
Yeah, thanks for that question. We think about it a little bit more about what pregnancy does to existing conditions. It's not as much about, you know, newly emerging conditions typically in pregnancy, but certainly pregnancy does have an effect on people's existing medical conditions. And sometimes those are diagnosed in pregnancy since patients may not have otherwise sought care for them outside of pregnancy. You know, the main things that we think about that for are immunologic disorders. So we do see that people who have conditions such as rheumatoid arthritis or inflammatory bowel disease or lupus, a lot of times their disease process is a little bit more quiescent or well controlled during pregnancy. We think that's because of the changes that happen to immune function in pregnancy, and that, you know, pregnant patients do have a little bit more immune tolerance during pregnancy, and that's because they have to tolerate this fetus that has, you know, DNA that's different than theirs. And so that also trickles down to, you know, changing sort of immune function overall, which is why pregnant people tend to get sicker when they get viruses. But that does make it so that there's not so much inflammation happening that, you know, can affect some of those disease processes. We certainly think about it for other systems as well. You know, from a cardiac standpoint, you know, we know that sometimes cardiac function can worsen during pregnancy, and that's because there's a lot more stress on the cardiac function during pregnancy, expansion of blood volume, more cardiac work. And so certainly we do see, you know, pregnancy affecting other illnesses. You know, we don't really know how pregnancy affects long COVID and how long COVID affects pregnancy, which we can talk about some more. But that's what, you know, a lot of this investigation.
One of the things that, thank you so much. I think it's so interesting to have this perspective into SARS-CoV-2 infection and how it may work. One thing that was really striking in the data presented, Chengxi, I think you, the EHR cohort had the sample size that let you really look at the trimesters of pregnancy and how they impact the likelihood of long COVID, and seeing that what seemed like quite a substantial risk decrease from infection in third trimester. I wonder, either Chengxi or Torri, if either of you might have be able to provide any suggestions or insight into how the trimesters might differ and why we would be seeing that big difference.
That's a great question. I mean, actually, I have no answer to that yet from the, you know, clinical and the mechanism interpretations here. However, from a data science perspective, And first of all, thanks to the data set, right, we just stratified the patients, get infected during different trimesters, which enables this more like, hypothesis generation. So we try to find how the pregnancy and infection during different trimesters and its impact on long COVID, they are different. So from the EHR cohort, we see they are different. However, why they are different? How to provide cares to those infected during the different trimesters requires, follow-up studies, which right now, a lot of big question marks and requires further investigations. And
I can just add that one explanation that we had for that as we were sort of looking at these data initially was that, sorry, I'm in the clinic. They're just making an announcement. Was that, maybe perhaps when we're looking at SARS-CoV-2 infection in the first and second trimester and then evaluating sort of subsequent long COVID, that a lot of the participants who had SARS-CoV-2 in the first and second trimester were still pregnant or in the early postpartum period when we assessed for long COVID. And we know that a lot of the symptomatology overlaps. We see increased risk of arrhythmias in pregnancy, VTE in pregnancy, brain fog in pregnancy, all of these things. And we also see more interaction with the healthcare system in pregnancy. So patients are seen in the latter part of pregnancy every single week. And so it's a high intensity, high access time for healthcare. And so we wondered if, we were sort of seeing some sort of, sort of masking of the difference, honestly, in pregnancy, because we're seeing a lot of the symptoms we see with long COVID when people are still pregnant, and we're seeing them all the time. And those sort of dissipate over time as we get further out. So the people who had those third trimester infections, then we're evaluating them more remotely from pregnancy. But we don't know. As Chengxi said, these are all just hypotheses that, I think are going to require more work to delve further into, but that was sort of as clinicians what we thought about when we saw those results.
Thank you. It's such an example, Chengxi, as you said, of how the EHR cohort and the observational cohorts have such strong potential to work together, and how EHR cohort is so suitable for finding associations, but for mechanism, we really need to look
Right.
clinically. Shifting gears for a minute, we had some advanced questions that we had received from potential participants, and one of them I thought would be very interesting to discuss, because I know there's some thoughts on this in the pregnancy cohort, in the observational cohort. The question was, is there any data on postpartum outcomes and experiences after long COVID during pregnancy? So when long COVID occurs in pregnancy, how might that affect the postpartum course?
Yeah, we're actually looking at that right now in both the EHR
Right.
cohort and the observational cohort. I think this is a question that's of really high interest to the long COVID community. I've had a lot of people ask me about this, and I've seen patients who come to see me to ask me about this. If I have a diagnosis of long COVID, how is that going to affect my pregnancy outcomes, and what do we expect in terms of pregnancy outcomes? And the data, we just really need information on this. We don't have it now, and I think that's what has really motivated the investigators in Recover to examine this question, is really the patient representatives in the long COVID community coming to us and asking for this information. And so we are moving forward with an examination of that in the observational cohort. And we're also collaborating with the EHR cohort and also trying to look at pregnancy outcomes among patients who have a diagnostic code for long COVID prior to the pregnancy. And so we are hoping to be able to provide information really soon related to that question, which I think is, so.
Right. To add one more comment is, so this seminar, this talks is more focused on how pregnancy impact the long COVID, right? Just as mentioned by Torri, and our ongoing effort is to study, vice versa, how long COVID impacts the pregnancy outcome. Is this lead to healthy deliveries or not? So we are working on that.
One thing that's, I think, Torri, as you mentioned, one thing that's important to note about the observational pregnancy cohort is that even though the pregnancy is over relatively quickly in time, people who were pregnant often become pregnant again, and it's a good opportunity to answer those questions. Perhaps I'll just ask one more question before we turn it over to the audience, which was also an advanced question about have there been pathology findings in placentas that correlate to long COVID? And is there any correlation between maternal vascular malperfusion and the development of long COVID?
Yeah, that's a great question. I mean, we know that there are placental findings with SARS-CoV-2, and this really came up, honestly, mostly with the Delta variant. The Delta variant of SARS-CoV-2 was particularly damaging to placentas and basically created a pattern of placental insufficiency, and we saw much higher risks of stillbirth during that particular time period with that variant. We don't know why that particular variant, but definitely that was demonstrated across several cohorts and demonstrated that there was, placental damage that resulted in placental insufficiency. To my knowledge, nobody has looked at that in terms of the development of long COVID and whether, that propensity for placental damage would also result in propensity for other vascular damage and, that could lead to sequelae and long COVID. I have not seen anybody examine that. Unfortunately, in Recover, we do not have placental pathology data. It is something that investigators have definitely talked about. There's an interest in it. There's a potential that, some existing specimens could still be assessed related to the placenta, but we would, need to acquire funding to do that. And right now, that's not part of the Recover protocol.
Great. Thank you both so much. This was just such a scientifically rich topic area. Quinn, maybe I'll turn it over to you.
Sure. Thanks everyone for such a rich discussion. We're going to turn it over now to the audience Q&A with some questions that we received in the Q&A chat, including a few questions that we received in advance. And just as a reminder to the audience, we'll also post a Q&A document on recovercovid.org with answers to what we discuss here and any questions that we cannot get to today. We've received a few questions from the audience about vaccination status and if this is protective against long COVID for pregnant individuals. I know, Chengxi, in your presentation, you mentioned there was data was a bit limited to have any confident conclusions, and Torri, in yours, you found results that were not statistically significant. I wonder if you could just comment on your reaction to that, if that is at all surprising, or if you find it consistent or it differs at all with what we would expect for non-pregnant populations.
Yeah, I can start with that. That's certainly a hot topic currently. I think that, in our data, we did show that the direction was towards protection, meaning that people who had been vaccinated before, the direction was towards having some protection against the development of long COVID. We just didn't have, a large enough sample size to be able to say that definitively, and that did result in sort of a wide enough confidence intervals around that estimate that it crossed one, which says that we can't say that that's statistically significant. But I wouldn't say our results are in opposition to other results. I think probably we just had a not large enough sample size to really look at that robustly. I think in the pregnant population, I mean, we know that vaccination is safe and effective. It's a strategy that we've been using, honestly, for decades, both for protection of the mother as well as antibody transfer to the neonate at a time when neonates are particularly vulnerable prior to the time that they can receive any vaccinations themselves. It really offers them protection in those first couple of years, couple of months of life, even up to 6 months, some of the studies would demonstrate. So I think that, broadly, the American College of OB/GYNs and Society for Maternal Fetal Medicine certainly support vaccination against COVID-19 in pregnancy. And the rationale for that is, reduction in disease severity in a population that's known to be at increased risk for severe disease, as well as some neonatal protection. I think our data would suggest that it's probably not different in pregnant populations than other populations in terms of vaccine being protective against long COVID. But I think it's just our population was a little bit limited, and I think it's hard in the EHR cohort because not all the vaccination data would necessarily been captured there. Patients who were vaccinated in other places outside of their centers is what's sometimes tricky to capture there.
Thank you. Our next question is for Chengxi, and it asks, did the analysis for trimesters effect take into account the patients who have reinfections?
That's a great question. And so all in our primary analysis, we just check their first ever documented infections during pregnancy. And to our colleagues, as far as I know, they just found, reinfection will increase the long COVID in general populations. But if this holds true for the pregnant females and this specific population, we don't know. So it's a great questions. And yeah, I think we can answer this by further investigations on this. However, for this study, we didn't investigate this. We just checked their first ever, infection.
All right, thank you. Our next question is for Torri, and it asks, has the influence of multiple pregnancies like twins on the risk of developing long COVID been explored at all, or are there plans to explore this in the future?
We have not explored that at this point. Definitely twin pregnancies are at increased risk for pregnancy complications. But they also have all the physiologic changes of pregnancy magnified ×2. And so, it's again this balance of, are we going to see increased risk sort of because of the increased risk of the pregnancy itself with the twin gestation? Or do we end up seeing even more sort of protection because you sort of do have, an even larger physiologic response to the pregnancy? I think that's all kind of to be sorted out. I think that it's going to be helpful to have the results from the observational cohort data comparing pregnant to non-pregnant. We do ask about multiple gestations in that, but honestly, typically in obstetric research, for better or worse, unless we're specifically focused on a multiple gestation population, we end up excluding them from a lot of analyses just because they are such a different population, and really do focus on the singletons. I think we have a pretty low proportion of multiple gestations, honestly, in the recover cohort. We didn't exclude them, but it's only 2 to 3% of the population, so it just ends up being a small part of any kind of cohort unless you're really focusing on multiples. But there's not anybody that has actually looked at that specifically, to my knowledge. It would be an interesting population in terms of looking at mechanism down the road for sure.
All right, thank you. Our next question is again for Torri. This person notes that it can sometimes common for mothers to develop conditions that are implicated or similar to long COVID, things such as POTS. And they're asking if you have any intuition or if we know anything at this point to help explain that difference, since from your research, it sounds like pregnancy is slightly protective against long COVID.
I think that this gets a little bit into that question of like, why did we see the difference by trimester? It makes me wonder if some of these conditions that definitely emerge are more affected during pregnancy. Potentially, we're sort of seeing that overlap still when we're looking at patients who are, in late pregnancy and postpartum, and then they get better once they kind of get out of that pregnancy and postpartum period. Whereas the people who acquired it in third trimester, and then we're looking at it further out from pregnancy. That's that's why we hypothesize maybe that we're narrowing that gap. There are so many physiologic changes during pregnancy. POTS specifically tends to get worse sort of in the 16 to 24 week period when we really have patients sort of have their lowest blood pressures that we're going to see because of the pregnancy effects and the progesterone effects and the dilation of the vasculature at that point. And so, we may still be seeing some more of those symptomatic patients in the pregnancy period. So then it looks like maybe it's not as protective, and then that pregnancy effect goes away, and then maybe it looks a little more protective for other reasons, because there's not as much inflammatory response, or there's other things that are sort of modulating that differentiation. But this is all clinical knowledge and hypothesis, kind of hypothesizing what could be happening here. This is an area that definitely needs, more work, and it's great that, Recover has invested in really focusing on this pregnancy population.
All right, thank you. Our next question asks, is it possible that the threshold to diagnose these conditions, including the nonspecific long COVID, may be higher for pregnant individuals compared to non-pregnant? And are there any biomarkers that could be used to help in this comparison?
Yeah, sorry, Chengxi, please feel free to jump in. I don't want to take all the answers here, but I think that is definitely possible. I do think that patients who potentially have symptoms of long COVID, that they could be dismissed in pregnancy for sure. Like, oh, I have this, I feel like tired all the time. We'd be like, yeah, you're pregnant, so I can definitely see like those types of symptoms requiring potentially a higher threshold for the diagnosis. I think that one of the reasons that we, wanted to publish just this prevalence and risk factors paper was really to raise awareness of the fact that, people could have long COVID in pregnancy, and maybe it's that and not, not just sort of normal pregnancy symptoms. It's always hard to sort that out. Pregnant people have nausea, they have GI upset, they have reflux, they have fatigue, they, have brain fog. I think it's a little bit hard to sort those out. So it is possible that long COVID was coded differentially less for them. That is definitely something that we have thought about. And it could affect our results. I think that is absolutely, it's an excellent point, and it is definitely something we've thought through. I think on the flip side, they could end up with the diagnosis more because they're in the healthcare system a lot more than people who potentially are at home, not accessing the healthcare system. All of these data have these flaws and things to think about, and I appreciate you bringing that point up because it's definitely something to consider. Oh, and sorry, Quinn, in terms of biomarkers, we, Recover has tried to sort of look at standard laboratory values at least to see if there's a particular sort of lab value phenotype, for lack of a better word, that would suggest that somebody had long COVID. What changes do we see in sort of more typical labs that we get in patients in the clinical setting? And is there something that would indicate perhaps that it's more likely that particular person has a diagnosis of long COVID? And unfortunately, there wasn't really anything that panned out that could tell us kind of like, this is the gold standard. We can draw blood and say, yes, this is long COVID. We don't have a tool like that now. I think, as we continue to get more information about long COVID and do some more detailed laboratory analyses and really look at, omics and different kind of modeling, I'm, hopeful that maybe we can get there so we can give people better characterization, but we don't have that capacity right now.
All right, thank you so much. I think we have touched on most of the questions that we received. So I think I'll wrap it up with one last question that we got in advance, and it asks, how can we better protect pregnant people from COVID and other infections? Should healthcare settings adopt any stronger protections, and how can we help communicate the importance of these measures? I guess I'll start with
Yeah,
you
I
again,
think
Torri.
that's clinical. I think that's a clinical question. So I mean, I think vaccination definitely is, what we talk about with our patients about in pregnancy is a very effective measure to prevent not only COVID-19, but flu is the other big one during respiratory virus season that we worry about in pregnant people. I think, I tell my patients, to exercise additional cautions, certainly during that cold and flu season, make sure that, if, I think we all used to or be around a lot more people that were sick and we don't worry about that. And, really trying to sort of avoid that, or if you're in that setting, use masks to try to prevent the transmission of that infection. And certainly really, really good hand hygiene, just going back to, just general infection prevention measures, encouraging patients to wash their hands, especially if they've been out in a public place and touching a lot of surfaces. I think, that's just important regardless. We don't want to, none of us enjoy being sick, but especially when you're at higher risk for complications of these viruses as you are in pregnancy. I think that's really important.
All right, well, thank you, everyone. I think that will conclude our Q&A session for today. So I want to say thank you so much to our presenters. Thank you to our audience for attending this seminar and engaging with the Q&A. As a reminder, a recording of today's seminar will be available on recovercovid.org within a few weeks, and we'll also be posting a Q&A document that has responses to the questions we received today, including some that we did not have time to address. But before we conclude, a reminder that researchers both within and beyond the Recover Initiative can now apply to use Recover data for ancillary studies. This includes data from 3 Recover cohort studies, adults, including pregnant adults, pediatric and autopsy, and biospecimens collected from cohort study participants. So interested researchers can submit an ancillary study proposal and receive approval. And researchers must also have independent funding to conduct the proposed study. And to learn more about that, you can visit recovercovid.org/ancillary. With that, we do hope you'll join us again. Please keep an eye on recovercovid.org updates and for a list of future seminar topics. Additionally, you should see a short survey on your screen right now, which asks for your feedback on this seminar. We will really appreciate if you could take a minute to fill out this brief survey. Thank you again to all of our presenters for your time, and thank you to our audience for tuning in. And with that, have a great day.
Thank you.
Thank you.